Potty 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 pod podcast. Potty 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 pod podcast. We love an audio stim and self-acceptance. It's the AuDHD Psych Podcast. Have you ever felt like your diagnosis just didn't fit, or you've tried different types of treatment and they just don't seem to work for you? This is really common in AuDHD. Hi friends, welcome back to the AuDHD Psych Podcast. I'm Aaron Howearth, clinical psychologist, and we are different, not defective. Today we're going to have a talk about AuDHD, mental health, and diagnostic difficulties. Just a friendly reminder that is general information only. This is not a replacement for assessment, diagnosis, or therapy. And if you are having difficulties, please seek out an affirming clinician in your area. Also, we may touch on some topics that might be quite triggering for people. So if you find anything challenging that we talk about today, please contact support services in your area. In Australia, that might be Lifeline, Beyond Blue, 13 Yarn, Suicide Callback Service, or Q Life. So I've got the delightful Dan with me on the other side of the camera, helping keep me on track today. And I'll ask Dan to ask the first questions, if you would.
Hi. So the first question is about co-occurrence and ADHD diagnosis. Why is it so complex?
So why is AuDHD diagnosis so complex? Well, I'm so glad you asked. There's a lot to it. ADHD is, as discussed in our last episode actually, AuDHD is more than just autism plus ADHD. It's also interactions, and it's also its own unique parts. Why is there diagnostic complexity in that? It's because for me to make a diagnosis, I need to make sure that there are a series of diagnostic criteria met, but I also need to understand other things that might account for those. In the context of neurodivergent folk, though, and mental health, we have a lot more difficulties than the average person. So autistic folk, I think it's something along the lines of about 40% of autistic folk will have a co-occurring mental health condition. It's really high in ADHD also, but AuDHDers, we're at an even increased or more increased risk of mental health difficulties, anxiety, depression, safety concerns like suicide and self-harm. And there's also diagnoses like borderline personality disorder, which I've spoken about, I think it was episode 9, and also bipolar disorder. Treatment-resistant depression is another one that often comes up for undiagnosed AuDHDers. Why does this matter? Because often we have the experience of diagnoses that are made without consideration of our neurodevelopmental differences, our cognitive brain differences. So we are more likely to have co-occurring conditions that are mental health or personality related. And there's a thing that we talk about called diagnostic overshadowing, and it's part of the diagnostic complexity. And it's where if I have a particular condition, or I'm seen to have a particular condition, that seem to account for the difficulties that I have. And it's really, Dan, you and I were talking earlier on about the observation fallacy. This is an idea of the symptom has to be diagnosable. It has to be observable for me to consider it in my diagnosis. For me to observe that characteristic, there's a couple of things. One, my diagnostic criteria have to accurately represent that particular symptom as an expression of the underpinning characteristics. But two, I need to understand the thing. So whether it's depression or in our case, AuDHD, I need to understand that for me to be able to observe it. But for me to be able to observe it and diagnose, you need to express that characteristic in symptoms that are in the diagnostic criteria. Now, unfortunately for many AuDHDers, ADHD can mask autism. We discussed this again in a few different episodes recently. And autism can mask ADHD. They can interact in AuDHDers to yield sort of complex interaction symptoms, but they also have their own expressions. AuDHDers have sets of characteristics that aren't seen in autism and ADHD. If I don't know what those characteristics are, those interactions are, if all I know is ADHD and autism, and that's what I look for, I'm not necessarily going to see it. If I don't recognise the masking effect they have on one another, I'm only going to see part of the picture. And ADHD, for example, shares characteristics or symptoms with anxiety and with depression. So if I don't see all of the ADHD or autistic characteristics, but I do see some that align with depression, I'm going to diagnose depression. And I'll probably then see that as my rose-coloured glasses for how I see you. That's diagnostic overshadowing. That's where I explain all of your experience through the label that I already have, the diagnosis that I have. And that kind of prevents me from thinking about other possibilities. I hope that made sense.
It did. So with overshadowing, what is the definition of it? As far as the most I have here is like the misattribution of new symptoms.
Yeah, absolutely. So it's, if I see your characteristics as depression, so depression sees apathy, amotivation, difficulty in getting up and doing things. Lots of ADHDers get really, really overwhelmed. Lots of AuDHDers get really, really overwhelmed, and we can't motivate ourselves to do things. We have repeated experiences of perceived failure, so we don't try to start things. In certain contexts, that can look like depression. If I have sensory experiences that are overwhelming me, that can look like the kind of overwhelm we see in depression. If I am really anxious because I constantly receive social feedback that there's something wrong with me, that can lead me to have an inattentive style of thought, looking for all of the anxious threats. It can lead to more overwhelm, but it can also lead to diagnosis of generalised anxiety disorder, for example, instead of perhaps autistic and ADHD characteristics. Diagnostic overshadowing is where I have a way of seeing you, and that's the way that I see you. I don't consider things outside of that label or that perspective or that framework for you.
There's a word here that I'm a little confused on. But what is the most common de-diagnosed?
The most common de-diagnosis that often comes up in and related to diagnostic overshadowing is borderline personality disorder. And I have talked about this at length in the past. Borderline, when we break down the diagnostic criteria, we see that borderline personality disorder, when it's diagnosed, it's underpinned by impulsivity, unstable sense of self, identity disturbance type concerns. We see a real rejection sensitivity, a sense that I'm not a valuable person, and I often will read ambiguous situations through the lens of rejection. So I want to be included, but I often see, because of my past history and my stress and trauma, but potentially I see rejection everywhere. If I have ADHD characteristics, emotional impulsivity, I'm likely to perceive rejection and immediately get really big emotions. I may impulsively engage in self-harm and suicide behaviours that we often see in borderline personality. I'll probably have the social difficulties that are really central to borderline personality. So if I live in a world where our diagnostic criteria are created, generally, historically, they've been based on research around the noticeable people with those characteristics in autism and ADHD, they're usually externalising biological males in clinical and educational settings where they come to the attention or they're causing difficulty for people around them, and that needs to be managed. If I am an internaliser, which biological females are more predisposed to be, or internalising males, I'm less likely to express my characteristics in those stereotypical ways for biological males or masculine presentations, externalising presentations. So my expression is likely to be more seen through a lens of borderline personality. My rigid patterns of thought, my emotional impulsivity, my impulsive behaviours, my rejection sensitivity are more likely to be read through borderline because it doesn't align with the current diagnostic systems that we have. And AuDHD isn't a diagnosis yet. It is still early in its research and understanding and really early in its diagnostic process. If I don't understand AuDHD, autism plus ADHD plus interactions plus more, I'm not going to see AuDHD and then therefore diagnose it. I'm going to reach for the best explanation, which often be borderline, might be bipolar, might be generalised anxiety, and then that will colour how I see your difficulties and how we create our treatment plan. And then that can really mean that I'm not having a full understanding of you and your experience, and I'm not necessarily creating the ideal treatment plan for you in your actual context.
It says that 1 in 5 autistic adults, the word here, have reported overshadowing.
Yeah, so that's sort of lived experience and self-report research, but yeah, 20%-ish of autistic adults have experienced either mis or misdiagnosis through diagnostic overshadowing, where something's been assumed because of a label, a diagnosis that's been assigned, and other things have been missed. We talk about borderline there before, and I say how I generally tend to talk about it in the context of biological females and internalizers. It's a really good example of diagnostic overshadowing. If I don't have the language or the label for AuDHD, I see you through that. I stop looking for other explanations. But then if I'm treating you for something that's deemed a personality disorder with all the stigma and judgment that comes with that, often it reinforces the difficulties. Often my understanding of myself through that lens makes me feel more broken, less worthy. But if I understand myself, if I have a developmental difference, because the two can coexist, it's not that these difficulties are always incorrectly identified in the context of neurodivergence. Often they do co-occur, often because of the extra stresses of being neurodivergent in a typical world. But, if I understand myself as one thing and my treating clinicians understand me as that, we're missing a big part of the picture potentially, and that diagnostic overshadowing contributes to that. And the diagnosis of things like borderline, and then the de-diagnosis when I'm correctly diagnosed as autistic, ADHD, or AuDHD.
So it's not a verdict on the character of the individual?
No, absolutely not. There is a lot of stigma around particularly personality, but it's literally a reflection of just my stress, my characteristics, and that interaction and that fit with my current environment that leads to what we call disorder when we diagnose. With the mental health concerns, if we haven't had the correct labels assigned in diagnosis and the treatment plans haven't been actually catered to who and what we are, we're going to have those treatment-resistant experiences. And we probably, and so many of us do, have that imposter syndrome, which expresses in lots of different ways. But that same underpinning characteristic can express in I'm not good enough, or I'm not doing therapy right. Or, I'm too complex for the treating clinician.
I'm too broken for it to work.
Yeah, but actually it's a systemic interaction. If I've got systems that aren't set up to diagnose AuDHD just yet, research is being done, and it's great researchers out there doing good work. But the system hasn't yet fully understood AuDHD, so it's not set up to diagnose AuDHD particularly well for the average punter, the average clinician, and therefore it's not a me thing if I don't get the correct diagnosis, or if the treatment that's for perhaps part of my difficulties, but not all of them, isn't actually, and I quote, fixing me. But that's a really great point to touch in on. When we do treat the difficulties that people have with autism, ADHD, AuDHD, other forms of neurodivergence, we're not treating you as a person, your underpinning characteristics. We're managing the difficulties that arise out of the mismatch between who and what you are and the sometimes unfair expectations of the environment. Change the environment, we can change how many difficulties we have and our strengths.
So how do you manage overshadowing?
How do we manage overshadowing? With really good formulation and differential diagnosis. So when I make a diagnosis, one part of it is I'm ticking some boxes. I'm looking at the diagnostic criteria and I'm saying, do you have each of these criteria? Do you meet these diagnostic criteria? A second part, and because that is not all of a diagnostic process, a second part is understanding you in your context and how you got to where you are right now. Who are you? What are the difficulties that you're having? How did you get here? What's keeping you here? And what's helping you either get better, have an improved experience, or have things not get worse, but also excluding things that can look just like that. That diagnostic overshadowing, when I say you meet the diagnostic criteria for generalised anxiety disorder, I also want to look at what else has those same characteristics, or the characteristics that are built into generalised anxiety disorder, and I need to make sure that they're not accounting for it. So in the case of AuDHD, I use generalised anxiety disorder quite often because the cognitive processes that a lot of AuDHDers engage in, very consistent with generalised anxiety disorder, very consistent with exceptional problem solving in many areas as well. So if I make a diagnosis of generalised anxiety disorder, I'm also looking at, could this be an AuDHDer who hasn't had this picked up before? I'm looking at, do you have a history of impulsive behaviours, impulsive shopping, maybe drinking too much, binge drinking when you were younger, substance misuse, gambling? Have you got a history across many contexts of inattention? In which case, it's not likely that it's anxiety causing that. If it's in lots of different domains, including where you feel safe, that's unlikely to be anxiety, more likely to be underpinning trait impulsivity. Do you have rigid patterns of thought in other areas of life? Do you have difficulty with concrete thinking that are consistent with autism? If you don't have any of those, I can exclude neurodivergence and say, yep, this is likely to be GAD, and anything else that's I call it a confound. I then exclude those as well to be able to say, yep, this is definitely generalized anxiety. Or, no, actually, a better picture here in the context of your history, your stress and trauma, your resilience, your supports, might be neurodivergence. But if I've never considered that because I see you through the lens of GAD, or generalized anxiety, then I'm not creating the ideal plan for you.
Yeah.
But that differential diagnosis and formulation, understanding you in your context, is how I really challenge diagnostic overshadowing and other diagnostic complexities.
We were talking before about asking clinicians for a formulation, but I'm going to say this in a very specific way.
Yeah.
Neurodiversity-affirming assessment.
Mm-hmm.
How is that much more important?
So I think neurodiversity aware assessment, I think, is really important. And the basic premise and principles of differential diagnosis and formulation come into play here. I need to have a full understanding of your developmental history. What were you like socially, physically as a child? Have you had a trauma? Have you had lots of complex big and little t traumas? Do you have a family history of characteristics consistent with neurodivergence or not? Have you had some environmental exposure to something or a brain injury that might look like neurodivergence if I'm trying to diagnose or differentially diagnose neurodivergence? I need to understand what your sensory experience is. I need to understand what your cognitive profile is to have a really solid understanding of you. And I hasten to point out, cognitive testing is not required for diagnosis of neurodivergence. However, it's exceptionally useful in treatment planning. When I do a full assessment and have that full formulation, all of the information to be able to say, this is you right now, as much as I can, these are the difficulties you're having that we want to manage, and this history, this is how you got here, I can say to you, what are your goals? What are the things that are really important for you to manage? And that's what we build our treatment plan out of. Being aware of the cognitive and sensory differences that some neurodivergent people have can allow us to A, help manage them in a treatment plan once we formulate, but also B, ensure that diagnostic overshadowing and miss or missed diagnosis doesn't occur.
How does late diagnosis in the context of formulation impact self-understanding?
So I think late diagnosis, and this is certainly my experience, and it bears out in the research as well, so a lot of the qualitative lived experience research, often we see ourselves differently. You know, I've told the story of peeing my pants in grade 2 before. Being diagnosed with ADHD helped me understand how I didn't get to the bathroom during the break, recognizing my own autistic characteristics through the experience of so many people that I've worked with, makes me understand, why didn't I just ask my teacher if I could have a break? For those who haven't seen, I think it was episode 17, I shared a story that I peed my pants in grade 2, and it was I can laugh at it now. It was a beautiful example of my ADHD and my autism marrying for joy. I needed to go to the bathroom at a break. I was in grade 2. I went out, my friends were playing handball, like this game. I started playing with them. I thought, I'll just do this for a minute and they'll go to the bathroom, and the bell rang and I had to go back into class. And then I realized I hadn't been to the bathroom. I asked my teacher if I could go, and she said, no, you've just had a break. You should have gone then. And so my inattention meant that I didn't get to the bathroom during my break. My autistic rules orientation meant that I'd been told, no, I should have gone into the break. I didn't ask again, and so I wet my pants. And again, as much as I didn't love being called pissy pants for quite some time after that, it is a really good example of, I thought I had done something wrong for many years. As I said, now I can laugh at it, but understanding that I am autistic and my rigidity, or, my cognitive rigidity, led me to not be able to ask if I could go to the bathroom again. And my inattention and the impulse to play that game came into play and prevented me from going to the bathroom earlier. Lets me know that I lived in a world that expected one thing, and that's not what I brought to the party. It wasn't about me being a bad person or not being smart enough or not trying hard enough. It was about characteristics that I have that weren't perfectly fitted to the environment that I was in. That reframe of self, for me, and again, this shows up in the literature, it really changes the way we view ourselves and can change our self-concept and how broken or right or worthy we feel we are.
Realising you're living life on heart mode.
Very much so, you know. It's funny that was something that Dan had said in a previous chat, and also that came up very randomly in some literature that we were looking at earlier tonight, living life in hard mode.
Yeah, no, it's a great term. I think it just sums it up. I love that story as well.
Can I just take a moment too, though, because I do practice from a neurodiversity-affirming lens. I also think that's context specific. You know, my favourite characteristic of my brain is my ability to problem solve. And I think put me against the average person in the street, and I live life playing on the easy level. Like, in that context, ask me to pay attention to something administrative for the next 2 hours. That's not even hard mode. That's like super hard mode for me, just to pay attention to writing letters or doing administrative tasks. So it's a win and a loss in different contexts.
So the next section here is about scripting for appointments.
Yeah.
In regards to asking for formation.
Absolutely. You know, we were talking earlier about how it can be quite challenging for a lot of our community, neurodivergent communities, to question a diagnostic decision or question how did you come to this conclusion, even if it's just genuine curiosity, because we communicate often quite differently, sometimes inattentively, sometimes too directly, and people take it as attack and insult, and it's not what we intend. And so we learn that we shouldn't ask these things, or that it's anxiety-provoking to do. And I say script. I'm such a big fan of scripts in so many contexts. And we'll actually include in the show notes and probably on our Insta, if I can get around to making a post up for it, just some general scripts. But, you know, things like perhaps, thank you for your diagnostic decision. I'm wondering how you came to that. Do you have a formulation that led to that decision and the treatment plan? And I know we talked about a couple of others, that scripts that we could use. What were those again, Dan?
So I'm concerned some of what I'm experiencing is being explained primarily by my existing diagnosis. Slow down and consider whether something else, including potentially neurodevelopmental factors, need to be assessed in their own right. Absolutely.
And that simple little script or something along those lines really neatly taps into that diagnostic overshadowing. If we feel that the diagnosis, and you know, I know my people, I know many of us will receive a diagnosis and we will go on a deep dive into it and go, well, that doesn't quite sit with me. That doesn't quite sit with me. If you come to me with those questions, I'll explain why I've made that decision, and I will have justified in my reports and in my notes how I've come to a decision. And that's a fair expectation to have. I might say to you, I understand that you feel this way, but if some evidence you've given me disagrees with that, I'll share that with you so that you have a full understanding of how I've made a decision. But it's your right to have that knowledge. This is your medical and health data.
Asking for a better formulation is reasonable.
Absolutely. It's absolutely reasonable. And it's about your healthcare. You understanding how someone came to a decision, and hopefully that gives you a really good understanding and relieves some anxiety or some stress. Also feeds into how we engage with therapy and treatment. If I don't know how you came up with a decision and it doesn't sit right with me, it's harder for me to engage with the treatment plan. But if you've explained that well to me and you've got a really logical process, I understand why you want me to do the mindfulness or you want me to do the exercise or whatever it is. And so I'm more likely to do it. Again, you deserve to understand, one, a formulation of you, but two, why we're asking you to do whatever the treatment is.
So, self-knowledge is a clinical safety issue. Unfortunately, it doesn't really continue on from that point. So, protective against decades of misfitting diagnoses is the rest of what it's written here.
Yeah.
In closing on the subject, what would you like the listeners to take away?
Well, I think just understanding that sometimes a diagnosis might not feel like it fits well, and that might be for a number of reasons. It might be that if I feel that a diagnosis doesn't fit well, it might be that I don't understand the diagnosis. And when I ask questions, when I ask for the formulation, that can help me understand and go, oh, okay, now I understand why this is depression. But it also might not fit well because it's not the right diagnosis for me. And actually, maybe I've been diagnosed with one thing and generalised anxiety is actually the correct thing that explains my experience when formulated with my entire history and context. But maybe it's actually that I've been given a diagnosis that is very valid, but also it only accounts for a part of my experience. And when I consider that sometimes my lack of motivation is depression-based, and sometimes it's actually the depression is based in my complex history of difficulties doing things, which leads to amotivation and an impaired self-concept and a sense of hopelessness that underpins depression, then I can recognize that, okay, I have co-occurring conditions. I have both a neurodivergent characteristic profile and also depression or anxiety or a post-trauma response and a significant trauma history, or whatever the complexity is. I guess on that, it's really important for us to just remember that we're valid people. We are different, not defective. And if something doesn't sit right for you, if treatments aren't working for you, you are well within your rights to ask the question, is this the correct diagnosis? It's not an attack on a clinician. It is simply a question about, have we considered all of my context? And I think most of us who have that question asked engage really, really well with it, because we become helpers for a reason, because we want to help people. And a lot of us leave our ego at the doors. So, I ask people to be really direct with me because I worked with really direct people who have been told, don't do that. So I can't speak for every clinician, but most of us want to be helpful. So it's your information, your security, your comfort that we need to be meeting. With that in mind, I should probably wind up for tonight. I think I've rambled on a little bit. I guess if you have a chance, have a think about a formulation for yourself. What is my history? What's my family history? What's my context like? What's led me to be here? And what might I be doing because of that? Not deliberately and as a bad person, but just because that's how I learned to keep myself safe in a setting that might be keeping me here. And what can't I change? What things might be genetic neurobiological differences or physiological sensory differences that I have zero control over, that maybe I've been beating myself up for, when maybe working in a different environment, living in a different environment can manage that difference and I can feel okay. Thanks very much, friends. I'll sign off for there, but have a great week. We are different, not less, and we'll see you on the next episode.